Thank you very much for logging in, and thank you again to Dr. Zerihun, who doesn't need any more introductions because he was presenting yesterday, and I'm sure most of you know who he is. He's basically double boarded in so many things, including internal medicine and intensive care. And he's a faculty member at St. Louis University in St. Louis, Missouri. And Dr. Zerihun, thank you for logging in and coming back to give us this part 2, and we're looking forward to your discussions. The floor is yours. Thank you.
All right, okay. Thank you so much. Good morning, everyone. So we'll continue from where we stopped yesterday, but I'll try to give you a quick summary. So I think yesterday what we said is COVID-19 pneumonia is not what we thought it is. We thought we are prepared as if everything about it is typical ARDS, but about 70 to 80% of the patients and does not have the typical feature of ARDS. Their problem is originating from the pulmonary vasculature, and they usually present, with silent hypoxemia. Some of them, might be in distress and progress in a different variety of ways. So right now, the working hypothesis is there are two types, type L and type H. Type L is the type where it's primarily vascular, or the disease is still in the pulmonary vasculature. And type H is when that disease extends to the alveoli. So the way to differentiate between the two is, obviously the vasculatures are far, or, for us to reach. So we assess the alveoli or the lung tissue, by giving pressure. And we assess the response to that pressure, or we measure compliance, we measure recruitability. So if the lung is sounds heavy from our assessment, or wet or edematous, based on imaging, based on pressure challenge, then that's type H. If not, it's type L. And we have seen the variety of presentation, the support system, the oxygen we can do, and some of the limitations of non-invasive ventilation, and also the process of intubation, the timing, the criteria, and some of the precaution we have to do. We discussed these things. I think one thing probably, I didn't mention is, I think it's probably a good idea to prepare a lot of, clear plastic. So I put them on my slides, which you are going to get, but, we use, we cover these patients whenever before we intubate them, so that the aerosols generation will be decreased. And I think that the same thing can be done for a patient on BiPAP, or, anyone. So I think some masks, some plastic covering, as long as the patient tolerates, is a good idea. So yesterday we talked, about the intubation. So again, going back, what we are trying to achieve is oxygen delivery. And this is our business, whenever we work around ventilator. So, by profession, physicians in general are, our business is oxygen delivery. And oxygen delivery, if you all remember from medical school, has two parts. There is oxygen content and cardiac output. So the oxygen content in the blood depends on mainly two things. One, the hemoglobin, or the RBC we have in our blood. The other thing is our oxygen saturation. The dissolved oxygen is very little, or contributes to about only 3% of the oxygen, content in our blood. So most of the oxygen is in the hemoglobin, and by keeping the sats up, that's how we deliver more oxygen. But we could have a lot of, oxygen content if the delivery or the cardiac output is not working. Then that again is not a good thing. So why I said this is mechanical ventilation affects both of these things. So when we start someone on a ventilator, it definitely affects by the oxygen content by improving the fractional oxygen concentration, and also by using pressure. And the mechanical ventilation also can affect the cardiac output. What's interesting is it can affect positively and negatively both of these things. As much as we hope that it will increase the oxygen content, it can also, worsen the oxygen content, because, at the extreme end, it creates dead space and so on. And the same thing for cardiac output, it can help. For example, we use it in, congestive heart failure patients who become hypoxemic. It can help, but it can also worsen the cardiac output, by affecting the right ventricle. And, I know it's very complex mechanism, but so, both ways are possible, both affecting positively or negatively. So, we have to take mechanical ventilation so cautiously. So again, what we are trying to achieve, because, it has got, the negative effect on the other side, the goal for us should be to maintain the lowest possible oxygen saturation, which is anywhere between 88 to 94. I think I have seen patients, staying awake as low as 70. For example, like we had patients on ECMO, we tolerate, that oxygen saturation. I think as, if the patient is, adapted to that, or the organ function is good, and you have a means of following that, you shouldn't push hard the lungs to get the oxygen. So, you always keep it to the minimum needed. And you also accept hypercapnia, which means you don't want to increase the respiratory rate or the tidal volume just to get the partial pressure of oxygen normal. And you just tolerate that, because every rate you increase, every tidal volume you increase will end up injuring the lung. So, the other, thing is, we have to, our positive pressure, we should adjust it so that it can give us the optimized cardiac output. You don't want to cause RV failure, because, you're going to be circling catch up, because, if that is affected, even if whatever the oxygen content you increase, you won't achieve what you need. The organs continue to fail. Another thing to think is transfusion, but, many studies have shown that, stored red blood cells is not effective oxygen carrier. So usually this is not something we do unless we are in a serious situation, where we are out of option. We don't typically transfuse to increase the, the oxygen saturation and oxygen content. So, but here is a potential intervention. So whenever we have oxygen failure, these are the options we have. Using the ventilator, we can increase the FiO2. We can increase the pressure to a limited extent. And when that route is, kind of getting used up, then we try to decrease the oxygen demand from the body, which means, the ventilator itself is a demand decreaser. What I meant by that is, whenever somebody's in distress, the work of breathing that leads to the demand of more oxygen by the diaphragm and the breathing muscles will account to almost 25% of the cardiac output. So, I mean, the fact that they are breathing like that, will make them hypoxic. So, by putting them on a ventilator, and resting them, we are decreasing demand, and you will see increasing their oxygen saturation. The other is, to decrease oxygen demand, we sedate them, sometimes we paralyze them. The other things we do to improve oxygenation is, we try to improve, ventilation and perfusion mismatch. there is some degree of ventilation perfusion mismatch in any normal person, because there are areas where the perfusion is really huge, whereas the ventilation is not that great. For example, on the West Zone 3 or the lower parts of the lung, there's a lot of blood, but there isn't much oxygen. So in those areas, the blood, most of the blood or portion of the blood won't be oxygenated enough. So at the end, when the final mixing happens, we will not have enough saturation. So by making that mismatch improved by using things like proning, pulmonary vasodilators, we can improve the oxygenation significantly. Other things we do is, ECMO is, possible, probably in Ethiopian setting, many be available. And, other things we can do is transfusion and cardiac augmentation, as I said earlier. So the goals, again, of mechanical ventilation in the past, the goal was normalizing blood gas, but, we learned the hard way that that is not good. So we didn't care about ventilator-induced lung injury. But the current concept is, the priority is minimizing ventilator-induced lung injury while giving, adequate oxygen to maintain, the organ function. So this is proven by multiple randomized control trials. So basically, don't be like a person who thinks only short term, like, because you improve the saturation, don't feel happy. What you have to think, or what you have to focus, is the long-term outcome. You don't want somebody to die down the line or to survive and be crippled. So preserve as much lung tissue as you can so that the patient can live with it. I think, this is to see the different side effects of, positive pressure ventilation on different parts of the body. It can cause, liver failure. It is amazing. The more you do it, you will see, patients, being affected significantly, liver failure, kidney failure, heart failure, increased intracranial pressure, lung injury. And, especially in COVID patients, you will see these things for sure. The minute you put them, on a ventilator, you will see them crashing, their kidney failing, their, liver failing, cardiac, going into shock and so on. So it's important always to remember this. And, that's why I'm kind of stressing that this needs care. So when we think of the modes of medical ventilation, the modes are dependent on, what triggers the ventilation, which means what starts. So it could be flow or pressure. So when the flow drops below certain level, the ventilators would, would start the flow or the breath. Or if the pressure drops below certain level, this is what we said. And the other thing is the limit, which is what determines the size of the breath. It could be your tidal volume, which you said, or it could be the pressure limit. So that's another key which determines the mode. And the other thing is the cycle. This is what ends the breathing. So, these are the modes of medical ventilation. The first one, you see their volume control. So this is initiated by the time, limited by the volume. So your target is volume and cycled by whenever that volume is done or when the time reaches. And pressure control mode, initiated by time. So that you set the inspiratory and expiratory time. And, you try to simulate the normal body. Usually expiratory time is much longer than inspiratory time in our body. So you try to give at least 2 or 3 times the inspiratory time. And what you set on the ventilator is the pressure, the highest pressure allowed. So the tidal volume will be variable in pressure control mode. And the ventilator or the breath is cycled by time. So on volume control mode, the volume is fixed. So you set the volume and the pressure will be variable. And the most popular method is the volume control, assist control mode. The other mode, we call it PRVC, pressure regulated volume control. This is a combination of, the two modes. So, it may make, patients more comfortable because, the problem why they get dysynchronous sometimes is when we set the flow. So whenever you put someone on a volume control mode, you set the flow. You say 60 liter per minute flow, and you won't get any more above that. So patients may not like that. They may want a higher flow. They want significant flow. So, and they will be unhappy when they don't get that. They will, the ventilator alarm starts to go crazy. So this pressure regulated volume control method allows flexible flow, so it may make patients more comfortable. The other, the next mode we see is pressure support. So that is again initiated by the pressure of the flow. So when that drops from a certain level, then above certain level, so the patient will initiate breath. And when that negative pressure, the patient, initiated, drop the pressure in the lung to, like, say, if you said, less than, -2 from whatever said, then, if the PEEP is 5 and the patient, starts breathing a negative pressure and make it all the way to 3, then the ventilator will start pumping gas, and which is a pressure support, the support you set and give the breath. So in this kind of mode, there is no set rate, so the patient always has to initiate the breath. The ventilator sees how much the pressure drops. Whenever it sees a drop, say by 2 from the PEEP you said, then it will give breath. If the patient doesn't initiate breath, the ventilator won't give the breath. So in this mode, the patient should be awake, and you should always put an alarm backup mode. Like if the patient doesn't initiate breath for 20 seconds, alarm or the apnea mode should be placed on the mode. The other mode, volume support mode, this is kind of the same pressure support. Instead of giving pressure, you just assure some volume, and the rest of the patient can get. CPAP, you guys all probably know, and SIMV is kind of the winning mode. Basically, you have a set rate, and if the patient wants to initiate breath in this mode, the ventilator only gives a little support. It doesn't give the full breath. But on what we call assist control mode, whenever the patient initiates breath, the ventilator will give the set tidal volume. Whether the breath is initiated by the ventilator or the patient, it doesn't matter. It will give that set tidal volume or set pressure you put on the ventilator. But on a SIMV mode, there are the ventilator, the breath is initiated by the ventilator have a fixed number, say tidal volume of 500. But when the patient initiates the breath, what it gives is it gives small support, and it will allow the patient to do the rest of the work if they want to breathe a larger tidal volume. So this is kind of an old mode, but we sometimes you can use it in kind of weaning. Many older pulmonologists, you see them using this mode for weaning, but nowadays, we don't use them as much. So these are the kinds of mode. If any question, I will answer at a later time. So again, those are the prior old modes. So nowadays, I think the focus is for ventilator manufacturers is ventilator patient synchrony. So there are more advanced modes, where these are included. So, we call some of them assist, ASV or assisted supported ventilation or proportional assist. So there are those more. So I think probably way out for this talk. And additional things we can do on the ventilator to help oxygenation. One, what we call inverse ratio, which means normally the inspiration to expiration ratio is 1:2 or 1:3. So whenever hypoxia, is significant and we want that to be improved, if it is critically low, then we can increase that inspiratory time. It could be 1, then that means, we'll make it 1:1 with the expiratory, or even more. And that's what you call inverse ratio. Basically, you are increasing the inspiration time, or the, the time where the pressure is applied. And PEEP and so on. I think we'll discuss those down the line. I think this is already I discussed, so I'm not going back there. So whenever we initiate mechanical ventilator, we have to, the initial setting, usually typically we put a tidal volume of 6 to 8 cc per kg. So there is no just, random number 500, 400 cc and so on. You should always, put them as cc per kg. And that the kg is not the patient actual weight. So rather it is the ideal body weight or the predicted body weight. So how do you calculate this predicted body weight? I will show you. I think it's on the next slide. It will come up, but there is a formula for it, or typically ArtsNet site has a chart. So I just open that and see what I do. I'll go and measure the patient, how tall he is, or I'll ask them how tall you are, or the nurses will measure for me. Then that height determines how my tidal volume I should be giving. So based on that, you come with a certain weight kilogram, and then you calculate either 6 cc per kg, 8 cc per kg. And usually the rate, you don't want crazy rate, so you want a low rate, but you have to be careful. If a patient comes to you breathing 30 times, and you sedate paralyze them and you put them on a rate of 12, what happens is the patients were breathing that fast for a reason. Maybe they were acidotic and they were hyperventilating. So when you take away their work of breathing and they were correcting their gas, and you put them on rate of 12, what happens is the patient will be acidotic. And, we have seen patients going into cardiac arrest from just this reason. So, you look at the patient and you try to simulate the patient once you put them, so that one, they get rested, and their physiologic need is addressed. Usually when we start ventilation, we start with 100% FiO2. Then, we look at the oxygen saturation. So you dial it down until you see start of 92, 94, and after that, if you have a capacity to measure blood gas, then you you will get a gas and adjust further the ventilator. So and you set a PEEP of 5 to 8. That's where you set them, and then depending on the blood gas or the oxygenation, you can ramp up that later. So once you initiate, I think immediately also there are things you need to check. One is a plateau pressure. So how do you get a plateau pressure? So plateau pressure is a pressure, you are trying to measure the pressure in the alveoli. So if you see on a ventilator, what you see is a peak pressure, which is the maximum pressure during inspiration. And to measure the plateau pressure, you have to stop the flow and equalize the pressure throughout that the lung and the airway system. So the pressure sensor is at the end of ET tube or somewhere. So when you stop flow, the pressure will equalize everywhere. So and then that's how you get it. So usually, if you see on a ventilator, there is a button called inspiratory pause, or you can find it, in one of the settings in the ventilator. So when you press that, look at the ventilator, you will see that the flow will be paused and there will be a flat line. Either the ventilator itself will give you a number, or you go there and look at it and, you find the plateau pressure. So, you don't want that pressure. You don't want that alveolar pressure greater than 30. If it is greater than 13, that means you are over distending the alveoli. And when that happens for a long time, you are going to injure that lung. So because you are using whatever the healthy lung that remain for the patient, and if you end up injuring that, healthy lung, the rest is damaged. So I think you are doing a disservice for the patient. So plateau pressure, you want it to be less than 30. The other thing is driving pressure. What is driving pressure? Driving pressure basically is the plateau pressure, which you get by pressing an inspiratory pause, minus the PEEP you set. So that is the difference of pressure. For example, if the plateau, by pressing the inspiratory pause, what you get is 24, and which is good, and the PEEP you have is like, say, 10, and what's the driving pressure will be 24 minus 10 is 14. So you want that to be, less than 15. So that is shown to be associated with mortality, just like the plateau pressure. So that's another thing, you look at. So it's important to check these things, immediately, and also every 4 to 6 hours. And if you see on the ArtsNet trial, that's what they do. So make sure this is maintained, because the lung could get worse through time or get better. So these things change. So you really need to follow them serially. So again, your SAT goal should be 88 to 95. If you see 99 or 100%, that's a sign that you need to go and decrease the FiO2 and coming down. So again, what we do is protective lung ventilation. And again, the reason you are doing that is, you shouldn't get focused on fixing the gases. You should focus on, making this patient productive at the end of the day, able to go out and go back to work and so on. For that, you have to preserve the lung. The way to do them is based on researches. One, you limit the tidal volume to 6 to 8 cc per kg using predicted body weight, not actual weight, because, ARDS patients have what we call a baby lung. Some of the lung is totally collapsed, especially the lower part, because there's a lot of water, edema, and, the weight is on it. So we don't have volume there. So that's why we call it a baby lung. And, you can lower the tidal volume as low as 4 cc per kg. And you keep the plateau pressure less than 30. You keep the driving pressure less than 15. You accept hypercapnia and lower pH, which means you don't need to crank up the rate or the tidal volume just to fix, the partial pressure of, carbon dioxide. I think I heard that there is no, blood gas system in Ethiopia. I'm not sure. I might be wrong, but if what you are using is in-tidal CO2, for representing the partial pressure of arterial, CO2, I think we have to be careful in interpreting that. I think that's a separate talk. I have a talk on that. If needed, I will present it. But it needs a very careful interpretation. But it can be used. If somebody knows what they are doing. So this is the predicted body weight formula in the table. So the male predicted body weight is 50 plus 0.91, height in centimeter minus 152. So you can use this formula to get it, or you can just put this table, somewhere in your iPhone in your picture and just, look at it, and then, get your predicted body weight, and then, your tidal volume. Again, back to lung protective ventilation. I'm coming back again to this. So, ideal body weight, low tidal volume, low FiO2 as possible, so accept hypercapnia. You have to use appropriate PEEP. How does PEEP protect the lung? So, if you remember the picture of ARDS, the top part is aerated, the middle part is, partially aerated, partially wet. The lower part is completely collapsed and wet. So whenever the ventilator pushes, the volume with the pressure, so there is a part where it opens up, and then whenever exhalation happens, it collapses. So that repetitive collapse, open will injure the lung. The pneumatocytes or the type 1 cells are very sensitive, very prone to injury. So in order to avoid that recurrent collapse, you have to give enough PEEP at the end of exhalation that you want to maintain the alveoli somehow open. So, and the way to do that is, there are many ways, but the most popular one is, using what we call a high PEEP or a low PEEP table. So this is what we do to protect the lung. So we use PEEP mainly if the lung volume is decreased, or if the FiO2 is really, above 60, because above 60% FiO2 is kind of toxic. Or if there is like obstructive lung disease, so this, PEEP might help us to counter attack what we call auto PEEP. So this is basically, for example, COPD patients, trap air in the lung. So if the ventilator knows to give the breath whenever the pressure drops, from certain number to below that, if there is a trap air, then the patient will have difficulty initiating the breath, because they have to work hard in order to get that number down. It's a little bit detailed concept. I think I have it on the initial slides I sent. So, my slides here and the one which is already, that's out there is different. So I'm going to send this one too, but there is a detail of that on that slide, so you can learn from it. But it's an important patient, especially on COPD kind of patients, and it's also important to measure when we have a problem like this synchrony. So this is what we call the PEEP table. So the lower PEEP table and the higher PEEP table. Basically, if you see, for example, if on here it says if the FiO2 is 30%, use PEEP 5. If 40%, use PEEP 5 still. If 40%, again, to go to 8. If it goes to 50% still 8, then 10. So there is a PEEP up to 24. The difference between lower and high PEEP is, if you see on the higher one, the PEEP escalates quickly, and in the lower one, the PEEP escalates slowly. So the way to choose one from the other is if the patients have, moderate to severe ARDS, which is PF ratio less than 200, then you have to use a higher PEEP. Because those have a higher recruitable potential. If the ARDS is mild, then you probably need to use the lower PEEP, so because there isn't much recruitable tissue. So after once you initiated mechanical ventilation, so there are things you need to look out. So one is that you give adequate sedation. So sedation should be titrated. We just don't sedate. We have to set a goal. We use typically in the United States RAS goal or SAS goal. I think this can be shared if needed. I hope you guys have some kind of protocol, and we have to check the vitals, the oxygen saturation. We get chest X-ray to make sure that we our breathing tube or the endotracheal tube is not advanced all the way to the right main stem, or if there is any complication or pneumothorax, it can help us with that. ultrasound these days is also handy to rule out these things. And we get, blood gas typically in 15 to 20 minutes. In Ethiopian setting, I think if you get the oxygen saturation and in-tidal CO2 and, understand the limitations of that, then you can follow those. And you should adjust the ventilator to limit ventilator-induced lung injury, which you already said. And, inspiratory pressure shouldn't be, including the peak, shouldn't be, more than 40. So you want to keep them below 40. If it is above 14, either the lung is non-compliant or there is some secretion in the ET tube, or the patient is biting the ET tube, or the ET tube is kinked somewhere you don't see. So you have to rule out, all those things. Or is there any pneumothorax, or, what else is going on? The patient develop, new edema, MI. So, you have to kind of think all those questions. So as you practice, you learn to go through these things. You also check, auto PEEP. You have to set the ventilator alarm because, for example, if you use a pressure control mode and you don't put an alarm for the volume is variable. So the patient may end up hypoventilating. So it's important to put an good alarm, safety alarm on the ventilator, so that you will be notified when there is a problem. And you should also, the reason you put them on a ventilator is to decrease the work of breathing. So if the patient is still struggling, it doesn't make sense. So you have to assess whether their work of breathing is minimized. And that's very important because while you are giving positive pressure on this side, if the patient works, which means he's negative pressure, then the net pressure will be too much. If there is a negative here, positive here, say if it is positive 30 here and the patient is generating negative 10 or 15, the total will be 45 centimeters of water source pressure. So that will injure. So you want to the patient to rest. And the other thing is, we look at the patient ventilator synchrony. So we'll try to satisfy them so that they don't fight the ventilator, because the more they fight the ventilator, the more lung injury and the worse the outcome. So again, these are the same things. So weaning. I think we should minimize the length of mechanical ventilation. This is very important. And, here in the United States, this is one of the quality metrics for ICUs. You have to reduce the length of mechanical ventilation, the number of days the patients will be on a mechanical ventilation, kind of average. And it's important because, this matters. The more somebody stays on the ventilator, the more sedation, the more injury, the more infection, the more they are on the bed. So, every outcome would be bad. So, early liberation from the ventilator is very important. And, for me, if the patients are still sick, I don't, bother them so much. I fix, the ventilator, tweak little things to make sure the lung is protected. But once things starts to improve, every day is a day for me to get that tube out, unless it's proven otherwise for whatever reason. So, and once we get to 40% FiO2 PEEP of 8 or so, then we stop the sedation and, we start to wake them up and see if they are ready for weaning, and then we put them on weaning trials. The other thing we do is early mobilization. You can mobilize patients while they are on the vent. If the patient, is calm and cooperative, there is no need to sedate them, really. I mean, you're worried, you may be worried about, potentially extubating them. So, if that's the worries, then maybe you can use restraints. But, what we call bag and drag, this is another critical important, you just, bag them and drag around. And I think in COVID era, this is probably not the right thing because we don't want them to be disconnected. But in other settings, you can do that. And it's proven to help outcome. And every day you have to try to do a spontaneous awaking trial and spontaneous breathing trial. The breathing trial, you can do them using pressure support. Typically 5/5 or so is one we use here. And the other is you can use TPs, basically means disconnect the ventilator and let them breathe while just the ET tube is there. You can give them some oxygen through that too. And the other progressive gradual weaning. And another thing to consider is cuff leak test. So this is you are trying to make sure there is no edema in the airway. What you do is you deflate the cuff of the endotracheal tube, and you see if air is passing around the ET tube. You will hear the leak. So if that leak is not present, that means the endotracheal tube is tightly held by the edematous larynx or airway. And if you extubate them, they may go into stridor and difficulty, and you have to reintubate them and so on. So cuff leak can help you avoid that, and you can try giving them steroid to lower this swelling. So again, when you wean, you want to make 40% PEEP 5 to 8. Their minute ventilation should be low. They shouldn't be breathing, and there's what we call rapid shallow breathing index. They should be hemodynamically stable. They should be awake. Once they do this, and then you put them on spontaneous breathing trial. Typically, the duration could be between 30 minutes to 2 hours, depending on the situation. And then if they pass this, then you will extubate them. These are the differentials of failure to wean. So I think I'll skip, and finally you'll extubate. So you should expect that there is a 10 to 15% extubation failure. That means you have to reintubate them, because otherwise if you want to be 100%, then you will end up putting a lot of patients for a longer number of days. So sometimes you have to get the courage and extubate them, or extubate them to non-invasive, or so on. So I think I'll stop here. These are some of the complications. So we have to complications of mechanical ventilations. What I already probably said. And mortality or morbidity of COVID-19 patients after being on the ventilator is very high. But I think this is improving. I think let's stop it here, and then we better. There are many slides, but I think they can read it, and I can answer. And also, I prepared some Word documents, so I think I'll probably be sending that to Malaku, and that can also be shared. So I think the previous slide, these slides, and the Word document I prepare, hopefully those combination would help.
So with that, I'm going to go in a couple of questions here. Let me start first with a question from Dr. Dagim and Dr. Davids, and it is really more focused on the new link to the the pathogenesis. Is this COVID virus attacking hemoglobin? Is this some kind of oxidative lung injury? So there are some new theories and new information that's coming out, and what your thoughts are there on that issue, Dr. Ray?
Yeah, I think there is that hypothesis. It's because COVID looks like something the high altitude hypoxia or kind of carbon monoxide poisoning and those things. So, but I think the theory seems okay, but I think the more working theory, which is accepted by the world's biggest figure, is that the mechanism is the vascular dysregulation, the pulmonary vasculature dysregulation. But I have read the articles which said where the hemoglobin, the iron being discharged out of the hemoglobin, and the iron acting as a free radical, and that kind of mechanism. But I think that is really far out. This disease has many other mechanisms like thrombosis. Microthrombosis is significant. Vascular dysregulation is significant. So there's a lot of unknown. This is a moving target, but I think the most accepted and by the biggest authorities is the vascular model.
So the other question is about PEEP. So one of the residents actually says, well, I have never put my patients in anything more than 12 to 14. And he says also none of his faculty have put anybody at this high rate. So he wants to know how safe is it when you go to 18 and 20 with all the, not only the lung injury, but pneumothorax and all that stuff that can happen. So the safety of.
Yeah. It's very interesting. As much as we know a lot about ventilator, we don't have a good way of setting PEEP really. I mean, I think if you see the PEEP table, it's kind of dumb just to look at some table and do the same thing for all kinds of people. But this is the reason is that we haven't found a better way of doing it. So I think doing, up to 15 is acceptable because if you see some of the meta-analysis of PEEP management, the higher PEEP, their mean or median is about 50. So I think whenever you have a very severe disease patient, if you put them around 15, it's a reasonable approach. So, and there are people who does follow that, like as Dr. Guma said, they just the maximum they say it is 15 because I mean more than that it may be more injurious than beneficial. So but I have had patients where I put 20 24 and what I do is I increase by 2 and I see the effect. I see what the driving pressure is doing. I see the oxygenation, I'll get blood gas, how the PF ratio is improving, I see the compliance. So I look at those things. So if I see improvement, if I see that the PEEP is actually recruiting, I tend to go. And sometimes we do what we call recruitment maneuver as well. So there are times where you need to use that kind of high pressure. But in general, I am preserved, and there are tons of ways of evaluating your PEEP, what it is doing. So there are about 12, 14 meters, and you can see them, what you're doing, from multiple angles and assess. So, but it is reasonable to say that, Dr. Guma.
So one other question is, do you think ventilator-induced lung injury is more common with these patients than any other, EADG pattern for other reasons?
Of course. Actually, I think as time goes on, that's what we are learning. Especially, for example, if you see on the Chinese, they were treating everyone like EADS. They are using the table, and so they're crazy PEEP and so on. And that's, I think, the reason very likely that they have such a high mortality on a ventilated patient. So come down, to Italy. Dr. Gattinoni is, from Italy, and that's where they kind of become observing and learning these things. And they used less PEEP, so the mortality there is much better. The same thing for UK, is better. So I think, part of the reason a lot of people died is the use of excessive pressure. So I think we should just know when to use pressure, when to use FiO2. So pressure works for edematous heavy lung, and FiO2 works for the other type. So, a mix of those use would be necessary at some point. But if the mechanism is more the vascular, then probably should use as little pressure as possible.
Perfect. So Dr. Zarion, do you have any experience or heard of this new ventilators, makeshift ventilators that are being distributed all over the world from China? Is there anything written about those things? Do they work like any other machine?
I haven't seen them, But I think, I imagine if they produce it, they are, considering the aerosolization and so on. So I think it should be, safe. But I imagine those are small ventilators, like kind of transport ventilators with, limbs of, expiratory limbs too. So it might be small, simple, but, practically can do the necessary things, but they need to be carefully, evaluated. So, but I don't know the details. If anyone knows them, please go forward.
So one other question here is there any alternative to suctioning via ET tube or our airway?
Yeah, that's, that's one of the worries, I have for Ethiopia, because I don't know whether they have the inline suction system. When I asked my friend, Dr. Tigis Bacha, she told me there is no inline suction system. So you have to bring the suction and then, disconnect, and, so I think that's a very, risky, especially, with the COVID. So I think any disconnection should be really discouraged. But the problem is the patients will have secretions, and you do need to have. So if you have to do, I think the recommended way is you have to clamp the ET tube, first make sure they are sedated and that they are not,
coughing.
dyspneic. So then, you clamp, you put, so, you have to have some kind of thought out process so that can be done safe. And also try to put something between the ET tube and the vent circuit that, lets you push the suction catheter in a tight manner. So I think that's something the system need really to figure out.
Yeah, Dawood, is there anything you want to add?
One thing for Dr. Tedros, and also for those intensivists from this side, is just to figure out exactly how much does it cost. For example, the intubation kit that we're talking about in terms of the ones that have inline suction system. Is it very expensive? Can we look at maybe advocating to purchase those? So this is something that we should look into.
Yeah, I think I agree. I don't think it's expensive. Honestly, if they think about it, it is very easy. But you just need somebody to purchase it, and I believe they are cheap. It's a small system, even it can be configured in the local setting, but needs to be actively thought of.
Rahel, any additional thoughts?
Hi, good afternoon, everybody. No, I think that was a very, very good job. The only other thing I could maybe add about suctioning is we do use plastic. I'm not sure if it would help much, but we do try to cover our patients' the head with some type of a clear plastic so that we can still see through, but still maybe do some of the procedures and things like that. That's the only thing I can think of. And plastic is kind of plentiful and cheap. It could even be like a trash bag that's a clear one. As long as something you can see through, it does give at least one extra layer or barrier of protection. That's it. But that was an excellent presentation, and you did a very good job.
Thank you.
Yep. So great, and thank you very much again to everyone who submitted the questions, and you guys have been really outstanding and joining on time and listening and asking questions and participating. So we'll stop here, and I thank Dr. Zerihun for this outstanding presentation again today. And it looks like to me that we may have to call him back for some other talks at some point. So thank you, and have a great rest of the day.